Hi everyone. I'm talking about our work published in the Clinical Journal of Sports Medicine entitled The Effect of a Comprehensive Injury Audit Program on Injury Incidence in Ballet, a 3-year prospective study. The study represents one of the first attempts to combine injury surveillance with functional movement screening to design individualized conditioning programs in a professional ballet company. We all know that dance, and particularly ballet, places extraordinary physical demands on the body. Injury rates in ballet have been reported to range from less than 1 to nearly 6 injuries per 1,000 hours of dancing. We also know that injury is multifactorial. It's rarely due to a single cause, but rather complex interaction of intrinsic factors like muscle imbalances and extrinsic factors like workload. Now, there's good evidence that having in-house medical care makes a difference. Previous studies by Bronner and colleagues and by Sonneman and colleagues showed that implementing on-site medical care reduced injury incidence in modern dance and ballet companies. But here's the question that drove our study. In a company that already has excellent in-house medical provision, can we do more? Can we use injury audit data and functional movement screening to design individualized conditioning programs that further reduce injury incidence? We designed a prospective 3-year epidemiological study. We followed a single professional ballet company over 3 performance years from 2005 to 2008. The company had between 52 and 58 dancers each year, roughly half male and half female. All dancers were included in the study. We based our approach on Van Meegen's injury prevention model, which is 4 stages: establishing injury surveillance, identifying risk factors, implementing interventions, and evaluating the effect. In year 1, we established baseline injury surveillance and implemented a pre-season functional movement screen, or FMS. The intervention in year 1 was based on the FMS alone. In years 2 and 3, we combined the FMS data with the injury surveillance data to design individualized conditioning programs. We used a new framework we developed called the Hybrid Intervention Model, or HIM, to ensure consistency in how these programs were constructed. We used a time loss definition of injury, any injury that prevented a dance from taking full part in any dance-related activity for 24 hours or more. We classified the injuries into 3 types: traumatic injuries, were those resulting from a specific identifiable event, like landing badly from a jump; overuse injuries that caused by repeated micro-trauma without a single identifiable event; and recurrent injuries that were defined as an injury of the same type and same site occurring within 2 months of the dancer's return to full participation. All injuries were recorded prospectively by the in-house physiotherapists, a key advantage of working with a company that already had a strong medical team. We also needed accurate exposure data. Exposure hours were calculated using detailed call sheets, performance schedules, and the dancer's union contract, which specified the maximum allowable dance-related activity. Over the 3 years, total exposure ranged from about 80,000 to 89,000 hours annually. The FMS is a screening tool that uses 7 fundamental movements tests, each scored on a 4-point scale. The tests included deep squat, hurdle step, inline lunge, shoulder mobility, active straight leg raise, trunk stability, push-up, and rotary stability test. Why use a generic movement screen rather than a dance-specific screen? That's an important point. We chose the FMS precisely because it's not dance-specific. It assesses normal movement patterns outside of skill and technique. Why does this matter? Because when a dancer is fatigued, which happens frequently in a demanding performance schedule, their skill and technique can diminish. When that happens, their fundamental movement patterns become exposed. That's when injury risk is highest. So by identifying deficits in these fundamental patterns, we hope to identify risk factors that might only manifest when the dancer is compromised. All the screening was done by the head physio in the first 2 weeks of each performance year, after the dancers returned from a 5-week off-season break. This ensured consistency in all the assessments. Overall incidence dropped from 4.4 injuries per 1,000 hours in years 1 to 2.05 in years 2 and 2.0502 in years 3. That's a reduction of nearly 54%. When we looked at female dancers separately, incidence dropped from 4.14 in year 1 to 1.71 in year 2 and 1.81 in year 3, a reduction of 56%. For males, incidence dropped over the course by a reduction of 53%. We used a Poisson distribution model to analyze the injury count, and the decline in years 2 and 3 was highly significant, with p-values less than 0.001. In practical terms, the mean number of injuries per dancer dropped from 6.39 in year 1 to just 2.78 in year 3. There's a huge reduction in the injury burden on these dancers and on the company. Recurrent injuries that come back within 2 months of return, dropped dramatically. For female dancers, recurrent injury incidence fell from 1.64 per 1,000 hours in year 1 to just 0.46 in year 3, 72% reduction. For male dancers, it fell from 1.51 to 0.43, a 72% reduction. This is important because recurrent injuries are often the ones that cause the most long-term damage and frustration for dancers. The fact we saw such a large reduction suggests that our intervention wasn't just getting dancers back to dancing faster, it was getting them back stronger and more resilient. We saw a greater reduction in overuse injuries compared to traumatic injuries. For female dancers, overuse injuries dropped by 62% from year 1 to year 2, while traumatic injuries dropped 53%. For male dancers, overuse injuries dropped 68%, while traumatic injuries dropped by 23%. This pattern makes sense. Overuse injuries are inherently linked to intrinsic factors, muscle imbalances, stability deficits, and movement inefficiencies. These are exactly the factors our intervention was designed to address. Traumatic injuries, by contrast, often involve an external event that can't always be prevented by conditioning alone. Our study demonstrated that by combining injury audit data with functional movement screening and using a consistent clinical reasoning framework like the hybrid intervention model to design individualized conditioning programs, we were able to achieve a significant reduction in injury incidence in a professional ballet company. We achieved this in a setting that already had comprehensive in-house medical care. First, it suggests that in-house medical care is foundational, but it's not the endpoint. There's more we can do to reduce injuries. Second, screening matters. Using a normal movement screen like FMS, not just a dance-specific screen, can identify risk factors that only emerge when a dancer is fatigued and their skill is compromised. Third, individualization is a key. Every dancer has a unique injury history and a unique movement patterns. Conditioning programs need to reflect that. Fourth, overuse injuries. Each represent a major burden in dance, may be particularly responsive to interventions targeting intrinsic factors like stability, strength, and movement efficiency. I want to acknowledge the limitations of our study. We didn't use a randomized control trial. In a high-performance environment like with a small company, that's simply not practical. We used Van Meegen's repeated measures model instead. I conducted all the FMS assessments were conducted by the head physio, which ensures consistency, but raises questions about generalizability. And the HIM was a novel model. It needs to be tested and refined. Despite these limitations, our findings offer a compelling case for integrating injury surveillance, functional screening, and individualized conditioning into the standard care of professional dancers. Thank you for listening, and you can find the full paper with this reference here. Thanks a lot.